Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm talking to Dr John Ribchester, a GP partner at Whitstable Medical Practice in Kent. John's practice is frequently cited as a leading example of the neighbourhood NHS in action, having spent years shifting services like diagnostics, day surgery and urgent care out of hospital and into the community. In this conversation, John explains the journey his practice took to develop this model, including the financial risks involved in building GP-owned premises capable of housing consultant clinics, diagnostics and an urgent treatment centre, and why he believes working as a single practice PCN helped them do this. He also highlights some of the challenges the practice has faced along the way, and the changes he thinks the government could introduce to make working in this way easier. And he offers some practical advice for GPs and primary care teams looking to create change from the ground up. As part of the LIMS Healthcare Network, GP Online has produced a new report for our subscribers on neighbourhood health and how the government wants it to be delivered. We'll put a link to that in the notes for this episode. MIMS Learning Live South is returning to London on Friday the 12th of June, and this year we're pleased to announce that tickets are free to book. This is the event you won't want to miss. It's your chance to boost your clinical know-how, connect with peers from across the UK and gain fresh insights that can make a real difference in your patients' lives. This year's clinical programme covers issues including obesity management, paediatrics, women's health and cardiology. We'll also be running a GP Business Hub stream aimed at GP partners, practice managers and PCN managers, which will be chaired by me. Sessions in that stream will cover practice finance, neighbourhood working, using AI in practice and how to meet the challenges of rising patient demand. Spots will go faster, don't wait. Head to mimslearninglive.com/south and grab your tickets today. And if you come along, do pop over to say hello if you see me. I'm delighted to welcome onto the podcast now Dr John Ribchester, who is a GP partner at Whitstable Medical Practice in Kent. John's practice is often held up as a successful example of neighbourhood working in action and the so-called left shift of services out of hospital and into the community. Part of the reason for this is because Whitstable Medical Practice has been working in this way for many years and so is perhaps further along this journey than lots of other parts of the country. So I'm really pleased he's joining us today to share some of his experiences of what being part of a neighbourhood NHS looks like on the ground. Thanks for speaking to me today, John.
Thank you. Pleasure to be talking to you.
Your practice in Kent is often held up as an example of neighbourhood working and the sort of thing other practices should be aiming for. When did you start working in this way and why did you do it?
It's been an incremental journey since the beginning of the internal market, when it struck me and some of my partners that there was this artificial divide between general practice over here and hospitals over there. So we started off many years ago with the idea of providing things that were simple to provide in general practice to the benefit of patients, and that would include things like physiotherapy, ultrasound, and then echocardiography, services that didn't require a lot of equipment or specialised rooms, but nevertheless meant we could help people from the community without and avoid a trip to hospital for them. Over the years, we've added many more services, and the step change was when we built our third medical centre, SW Medical Centre, to be twice the size we needed in order to house a variety of diagnostic, day surgery, outpatients, urgent care and consultant colleagues.
That's a really interesting thing about what you've done, because obviously you did that before we were in this position now where everybody's saying this is what needs to happen and this is the general direction of travel for everyone. But that must have been a big risk building that surgery, and it is a GP-owned premise, isn't it? You own that premises. How did you go about doing that, and did you feel confident that you would get the revenue back in to cover the costs of it?
We started with a strategy which was, sound possibly familiar, better care closer to home with shorter waiting list and more economical for the taxpayer, so that most of our services outside of general practice are provided at less than NHS tariff and with shorter waiting lists. So that was our principle. We recognised we couldn't do this from ordinary GP estate. And yes, we did take a risk because, as you probably know, the estate that is used for GMS, General Medical Services, is reimbursed to a practice through something called CMR, otherwise known as notional rent. However, other services that a general practice provides are not reimbursed at all. So our principle for half of our biggest building was to try to attract community contracts in order to pay the mortgage, because it is an ordinary high street mortgage, and also pay the staff, pay for the equipment, and hopefully make a small surplus.
Has that worked, do you think?
It has worked, but not in the ways we thought it would. Some projects that we thought would actually be clinically and financially viable, such as gastrointestinal endoscopy, didn't work. But other projects, the numbers have gone up enormously. We have an urgent treatment centre, which is our biggest contract, that sees 150 people a day, over 50,000 people a year. It's open 12 hours a day, 365 days a year, with X-ray, with point-of-care DVC testing, and its own virtual and face-to-face fracture clinics. That is our biggest project. We have over 30 staff. We employ our own radiographers for the X-ray, and we also employ radiologists for reporting the X-rays. So that's a big undertaking and has become a very significant part of the building. Our day surgery includes cataract surgery, hand, wrist and forearm surgery, dermatological surgery, and we have a number of oscopies as well. We have hysteroscopy, flexible cystoscopy, nasendoscopy. In terms of other diagnostics, we have echocardiography, ultrasound, plain X-ray, which is open 12 hours a day, 7 days a week. Currently, we have an MRI and CT sitting in the car park, although that's not necessarily a permanent arrangement. We also have a range of outpatients, some of which are consultant-led, some of which are GP with an extended role-led. And we now have recently, over the last couple of years, a primary prevention arm, which we call our lifestyle medicine arm. We are an RCGP active practice. We support park run, and we have a lifestyle medicine committee, group consultations, and intranet resources for primary prevention, which is one of West Streeting's three shifts, from treatment to prevention.
Wow, that's a lot of stuff. And do you effectively employ the people to do most of those things? I mean, I know you mentioned there was some consultants and outpatients. I'm assuming that's the hospital coming out to do that. But a lot of those diagnostic services that you run, are they things that you run through the practice with you employing people to do it, and then you have a contract to provide that service?
Yes, and in fact, we do actually employ the consultants as well.
Oh, right, okay.
And we also employ our theatre team, we employ our sonographers, we employ our radiographers as well. We find it much more responsive to actually employ people than to rely on another organisation employing them. It's much simpler to employ people direct, and they feel more part of the team and more accountable as well. And it feels much more like a joint venture.
If these are all services that you're now providing in the community, did you face pushback from the local hospital trust when you said you wanted to start running these services locally in Whitstable, or did you convince them to become a partner in this somehow?
It's a good question. It has been quite a journey. First of all, you say the hospital. If you divide the hospital into the clinicians and the managers, the clinicians, no, we got no pushback from them at all. The managers, yes, we did get some pushback in the early days, and we've gone through a sort of three-stage process. In the early days, it was, how dare you, you're trespassing on our turf, this isn't right. Then we got to the second stage, which was actually, we're not coping with everything that's thrown at us. So the fact that you're providing X-ray and ultrasound and echocardiography, we will give you subcontracts to try and clear our waiting list a bit. So that was the second stage, as it were. And the third stage, which was where we are now, is a mature relationship where the East Kent Hospitals University Foundation Trust rent an 8 consulting room suite from us. They have 20 plus specialities coming to that 5 days of the week, and they use our diagnostics on site. So it's not just a question of lifting and shifting what they're doing, it's actually changing the model. For instance, with respiratory clinics, they will tell us we are probably going to want 8 chest x-rays today. So we block that out from our x-ray unit, so the x-rays are done on arrival. So the consultant sees the patient and the x-ray at the same time. Patient journey is much faster. The satisfaction for the consultant is higher because they're seeing the investigation and the patient both at the same time, it works better. And there are many other examples where we have changed pathways, which is what excites me about it. It's not just re-providing the same service in the same way. It's using the diagnostics and our consultant colleagues' knowledge in a more efficient way to give a better patient journey with less episodes of attendance in a patient's journey to diagnosis and completion.
It sounds like a brilliant model. I'm not surprised that you often get held up as a big example, because this sounds exactly like the kind of thing the government's talking about doing when it talks about that shift from hospital to communities. Have you had loads of ministers and NHS England bodies down there coming to look at what you're doing?
We do have a constant stream of visitors, it's true. And the other part of it I haven't mentioned is that we were part of the encompassed multi-speciality community provider, MCP, 2018. During that time, we did start multidisciplinary team working for the most frail people. Despite the talk about the 3 shifts, the thing that most people are starting with is concentrating on the frail elderly to prevent unnecessary admission. And we've been doing that for a decade now, and consequently have very low rates of admission for the frail elderly.
Because obviously a big part of creating a neighbourhood NHS is, like you say, it's working with people who are most at risk of admissions, people who are high users potentially of NHS services, and working out a way to keep them healthier and keep them at home for longer. So how exactly have you done that, and who are you working with on that? Which other partners in the system are you working with?
As I say, we did start it 10 years ago as part of Encompass. That covers 180,000 head of population in 5 what we called community hub operating centres at the time, and they all, bar one of them, which was too small, turned into PCNs.
Yeah.
Each of those had a hub, which is an MDT basically. And to answer your question, who do we work with? We work with the Community Trust, and their members of their team attend the hub, including the community frailty team, the medication optimization service, occasionally respiratory nurses. We also have a social worker attends, community organisations such as Age UK, including Dementia and Me, an organisation called Red Zebra, Carers Support. We also have people who are social prescribers that we employ direct under the AIIS scheme, who have got access to the entire range of voluntary organisations. Occasionally the Mental Health Trust attend, and also occasionally the community wardens. So it's very much a holistic approach, using everybody that's appropriate, having first risk stratified patients into the most frail, because we recognised and confirmed 10 years ago that the top 5.9% of the population accounted for 80% of the cost of urgent care. That's why we concentrated on that.
If people who are listening to this don't remember, this was the NHS England's Vanguard programme, wasn't it? Like you say, in 2016, it started out, and you were one of the areas that was the multi-specialist community provider arm of that programme. With that, there was a big focus on trying to integrate care. Did you get a lot of extra money and support and resources to do that? Because what I'm thinking is, obviously, you're 10 years down the line in doing this. There's some people who are quite early on in this journey who might be listening to this podcast, and there's not really loads of extra money to deliver neighbourhoods. And I was wondering how you did that. Did you need extra resources to get something like this off the ground?
Well, we did get extra money. Between the 180,000 patients, our particular Vanguard, Encompass, received 1.1 million a year for a period of 3 years, which sounds like a lot of money, but it's not spread over such a large area. I'm pleased to say the sort of end-of-term report at the end of 3 years showed significant activity deflection, such as 33% less short-stay admissions, 6.4% less A&E minor attendances, 8.2% less emergency admissions across the board, which was calculated by the NHSE central team to represent 3.4 million of planned model forecast savings in the final year. So it's a shame for me that this programme didn't carry on for a 4th or 5th year as well, because we got better and more efficient every year. So it more than paid for itself.
Do you feel like this whole push towards neighbourhoods, it's been going on for a little while, but obviously the 10-year plan under this Labour government is really intending to drive this forward across the country. Do you feel like this is just all really kind of replicating the stuff that you were doing 10 years ago, or is there anything in this that you feel is a bit more different?
I think it feels very similar to what we were doing during the nuclear models trial, and it's interesting. It's taken 10 years to come around again.
Yeah.
I completely applaud the three shifts. I mean, I can't argue with those at all. I think the difficulty that the whole system is facing is that there appears to be no new money to speak of. That being the case, the only way better neighbourhood care can be created is by decommissioning the cost of hospital care. As you're probably aware, England is an outlier in how much of the health service budget is spent on hospitals as opposed to community care. In England, it's roughly 90% of the NHS budget is spent on hospital care, 10% on the whole of community care. That includes general practice, community trusts, mental health trusts. If you look at Europe, France in particular, it's something like 34% is spent on hospital care. Germany, it's about 42%. So, in other words, an awful lot more of their health budget are spent in the community in order to keep people in their own environment and to reduce the number of people not unnecessarily going to hospital. The fact we're such an outlier is a significant problem to improving and creating neighbourhood care, in my view. To try to decommission some of the costs of hospitals has always been the challenge. No one's ever succeeded in doing this. If it can succeed, then I think neighbourhood healthcare will succeed. If it can't succeed, then I think the system will stay as it is and sadly will become more and more unaffordable.
Based on your experience, is there anything that the government could do centrally, or you think they should be looking at doing centrally to help facilitate that? There's a lot of talk in NHS England about changing funding flows, and that seems to be like a really important thing to happen to be able to get more care out of hospital into the community. But it's not really clear how they're going to do that and what that means. I mean, have you any thoughts about how that might work or how that could work best?
Simply, I think the money should follow the patient. If general practices like ours start doing diagnostics, outpatients, day surgery, urgent care, then from the commissioner's point of view, that's seen as a rather frustrating extra cost because they don't commission the hospital. And yet, more and more percentage of what needs to be done is being done in the community. But it's seen as a sort of an add-on extra cost to the commissioners. If, on the other hand, you said, well, if this work is going on here at less cost per unit, by the way, then we should be decommissioning what's happening in the hospital and recommissioning outside. I do sympathise with the hospitals. They do have fixed costs. They do have massive estate, often in a poor state of repair. So they've got problems. But to have smaller and more efficient hospital services who are doing only what hospitals can do, and to do everything else in the community seems like a better model to me. I mean, with modern technology and modern equipment, an awful lot of the diagnostics, day surgery, oscopies, urgent care, point of care blood testing can really work well to keep people out of hospital. And unfortunately, the most expensive place to do anything is in a hospital because of the infrastructure cost. So, some difficult decisions probably need to be made. But to make hospitals leaner and doing what only hospitals can do, and to get everything else as much as possible done in the community with good governance around it, obviously, both clinical and financial, seems to me the way to make the NHS work.
Yeah, definitely. Your practice, you have 3 buildings now, and you're basically a single practice PCN, aren't you, which covers the whole town. Do you think your size and the fact that you're a single practice PCN has helped you to develop this way of working? Absolutely,
yes. I mean, we have 45,000 patients, 23 partners, nearly 300 staff, and 3 clinical buildings, and actually a 4th building, which is our admin block. Now, I don't think you can make the decisions to invest in all these staff, all this equipment, and to have all the clinical and financial governance in place as a multi-practice PCN. I don't know of one that's done that to this extent. So I think, it's difficult enough to take on, huge financial burdens of large mortgages and to create and maintain all of these community contracts to pay for everything you need. As a single practice, 2, 3, 4, 5 different practices, I think that really increases the complexity. I'm not saying it's impossible, but I do think it's much more of a risk working with people that you're not actually partners with.
It's interesting because I've been talking to a few people recently about the fact that estates are going to be a real challenge in delivering this. Do you think the rules around rent reimbursement in particular, you sort of touched on the fact that you only get reimbursed for the parts of the building that are used for GP services. Do you think rules like that and valuation, do you think they all need to be looked at and changed to help make this easier for people to do?
Yes, I do. I think there are 3 things that one could do, well, in my view, quite simply, although it might not be as simple as I think. I mean, first of all, any space which is used for neighbourhood health could be allowed for charges under CMR, current market rent, otherwise known as notional rent. Our biggest building, only 50% of it is rent reimbursed. The other 50%, as I say, we rely on these contracts. And that's just my second point, which is the contracts we have for diagnostics, outpatient, urgent care, day surgery are annual renewable. Now, that's a big risk for general practice because if at the end of a year, for instance, the commissioner of the day decides, I don't want to do this anymore, then we have a huge redundancy bill, we have empty space and unused equipment. That would scare most GPs off. And the third thing that I would suggest changing is to allow an annual increment equivalent to the cost of providing the service to apply to community contracts in the same way as it does to hospital contracts and indeed to private hospital contracts where they're doing NHS work. Currently, we either get no annual increment to account for the increased costs of staff, consumables, etc., or a minimal one, which means that year on year, the financial value of a contract goes down and down and down and can reach the point of being unaffordable. We've reached that with 2 of our contracts now. We're operating at a loss. And that was never the intention. We would be hoping with a 10-year plan this might change, but difficult decisions have to be made if through this attrition costs go up and yet reimbursement doesn't.
Those are all really, really, really good points. That's actually the point about the length of contracts for community services. It's very, very difficult, isn't it, for maybe community services as well to invest or to take on long leases in buildings and stuff when they've only got guaranteed contracts for a year at a time. It makes all of that very difficult.
Well, you're absolutely right. In our case, it's not a lease, it's a mortgage.
Yes.
There's no getting away from that. And yet, very often our annual renewal contracts are renewed a month or 2 after the year has expired. So for a month or 2, you are carrying on and putting in invoices, but you're still not sure if you've actually got a contract for the current year you're in.
Is there anything else you're doing around the kind of prevention agenda that we've not spoken about already?
Prevention is an interesting term because most people you talk to when you're talking about prevention are talking about secondary prevention. In other words, you've got diabetes and you try and control it well enough that you reduce the chance of the complications of diabetes. That's secondary prevention, but to properly go upstream and do primary prevention, in other words, do prevention before someone gets ill, is really the game changer. I feel quite passionate about this, having done a certificate in lifestyle medicine. We are trying to get this into practice, despite the fact there's no funding for primary prevention at all. The concept of the 6 pillars of lifestyle medicine, all of which are evidence-based and proven, which includes proper nutrition, decent levels of physical activity, restorative sleep, avoiding harmful substances, not just the obvious cigarettes and alcohol, but the stuff you're getting in food and the stuff you're breathing in terms of pollution, maintaining social connections and stress reduction. All 6 of those pillars are evidence-based and worth weaving into consultations. The difficulty is that a lot of hospital and GP doctors aren't trained in this and what the evidence is and what it shows. And the other difficulty is there's no time allocated to this. One can weave a few sound bites into a 10 or 12-minute consultation. But to do this properly, you need a lot more time than that. So we are doing group consultations to try and see groups of people and therefore give more time to each person by being in a group. We're doing group consultations for people with chronic pain. We're doing group consultations for people for menopausal symptoms and also for musculoskeletal symptoms. So we're getting those things going. But again, it's difficult doing it when there is no sort of contractual basis for this, but nevertheless highly worthwhile. Something that I think there's about 3 medical schools training in lifestyle medicine at the moment out of the whole of England. It needs to be all the medical schools, and it needs to be all of the doctors and nurses who are currently working.
Everything you're doing sounds really, really brilliant. But what are the benefits of working in this way for the staff you employ, and also what have patients said to you about it all?
Starting with the staff, that's something I didn't foresee. Staff satisfaction and GP satisfaction is enormous. The fact that you can get diagnostics done on site, and if it seems urgent, get it done quickly. So, if I think someone's got a collapsed lung or a very significant chest problem, I can get a chest x-ray done within an hour, and I can either refer someone into hospital knowing that they really need to go there, or I can reassure them and myself that they don't need to go there. Also, from the GP point of view, the very fact we've got a large number of outpatients diagnostics day surgery going on means there are career development opportunities in all of those. Makes life exciting rather than joining general practice and having to look at elsewhere for your education and your extra string, if you like, if you want to do general practice and something else. And from the nursing and other clinicians' point of view, and from our non-clinical staff point of view, we never have unfilled posts. In fact, in some specialties, we actually have a waiting list, which is pretty unusual for general practice. People want to come and work in this way with all of this going on. So GP staff satisfaction is really high, and opportunities for education, training, and indeed research are all there. That's a good thing. From the patient's perspective, the satisfaction was fairly good in the first place, but it's sort of becoming embarrassingly good. It really has. I mean, if I look at the stats, 98.3% of patients recommend the surgery to friends and family. That's pretty high. 97.2% of patients feel they're treated with dignity and respect. We have a weekly newsletter. Not a week goes by without a patient's story in there saying, thank you for the urgent treatment centre. Rather than me waiting for hours in hospital, I came to you. I was in, x-rayed, plastered and out in less than an hour. Stories like that are really very good. And I should add that all of these services, other than general practice, are open to anybody under NHS choices and the urgent treatment centre, obviously. If we do a postcode search, which we do quite regularly, only 50% of our urgent treatment centre patients come with a Whitstable postcode. The other 50% come from mainly East Kent, but some from West Kent, because experience has taught them they'll be seen quickly and treated with respect. Again, good for them, but it also gives us, a positive stroke as well. So we carry on.
And so all the diagnostics as well, obviously, they are for other practices in your area, not just in Whitstable, to refer into too.
They are, yes. They're open access to GPs. The DVT service is used the first choice by many general practices because it's a faster service. I mean, we have the clinical assessment, the D-dimer blood test, and then the ultrasound available very quickly, and then we dose people, if appropriate, with anticoagulants and also investigate for underlying cause of the DVT, and then report back to the general practice. And this happens very quickly, and I should add, at less cost than the hospital service.
This move toward at-scale working, trying to move care out of hospitals into the community, there's been pushes on this repeatedly over the years. Why has it worked in Whitstable when it hasn't quite so easily or so quickly elsewhere?
I'm sure there are other areas that have succeeded as well, but what we have done is we have retained personal lists. So although there's a team of GPs, there are 3 teams in 3 clinical buildings. So the number of GPs you're likely to see is not the whole 23. It's a third of that. Whether you're being seen by a GP, a nurse, a theatre team, whatever, you have a main GP, you know where the buck stops. And that, I think, gives an accountability to the GPs, but it also gives satisfaction to the patient. They have a GP and they know who that GP is. So I think that's one of the success factors. I think the fact that we're a democratic practice with a management team made up of 4 elected GPs and non-medical managers who are specialist managers helps us as well. So we have a finance manager, a GMS manager, a clinical services manager, quality and safety manager who also deals with complaints. And we have a second tier of management below that, which includes managers for all the departments, including practice nursing, the urgent treatment centre, IT, etc. So we have a pretty structured system of management, and I think that helps us with our clinical and our financial governance.
And finally, what advice would you give to other GPs and PCNs who are trying to make this work?
First of all, start off with a vision. What is it you want to do? If you do want to deliver comprehensive integrated healthcare close at home with great satisfaction, this is a model worth considering. Although I do sympathise with colleagues who can't recruit because a lot of GPs are firefighting and anything like this would seem a bit of a big step. I would certainly consider working at scale. If you are a big practice with a large number of patients, your chance of doing this, I think, is much higher than if you're a small practice. You're not going to want to develop expensive services in expensive estate unless you can populate those services and, quite frankly, earn the money you need to pay for your staff, your estate, your consumables, etc. So scale is important, a decent vision is important, and then having a decent management system, which is part clinical, part non-clinical, which is above and beyond the management system you'll consider for running GMS alone. I think these are the important factors. And do talk to everyone around you. Do talk to your commissioner, do talk to your local hospital trust, community trust, and mental health trust, because this is not a lone effort. It's a holistic effort. And if everybody is interested in doing things differently like this, you've got a much greater chance of success than if you're trying to do it on your own. The last thing I'd say is that change tends to happen from the ground up. If you wait for the centre to tell you how to do it, you're probably waiting an awful long time, because they know the things that are important to them, but they don't know necessarily how to be a good provider. You are the best person to work out how to be a good provider of neighbourhood health. By all means, take examples from other people who are good at it as well, but it starts with you at the delivery end. So it's worth thinking about. Don't wait for guidance on high, because that will be so generic that it won't necessarily help develop your new model.
That's really good advice. Well, I really appreciate you talking to me today. Thank you very much for your time, John.
Thank you very much for the interview. It was a pleasure.
Well, that's it for this week. Thanks again to John, and thank you for listening. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.